Hey guys, it's me, your friendly neighborhood ER doctor, and today we're going to talk about ventricular rhythms. We're going to skip over the junction until next week and talk about the ventricle because it's a little more straightforward. Before we do that, I just want to take a minute to review a couple of things from our past lessons based on some feedback that I've received from some of you. I just want to remind you that in our atrial fibrillation rhythm, we see what amounts to scribbly lines, which are fibrillatory atrial waves, and we're going to call these non-discernible P's, and we're going to note with this that our R-to-R intervals are inconsistent. So in general we say that this is irregular, meaning that there's no pattern to the irregularity. Then I want to contrast that to our friend down here, Atrial Flutter, which has a sawtooth appearance, is often very regular, and often very predictable. And it's important that you are able to identify these two things because oftentimes these are going to be amongst the most common dysrhythmias that you're going to find in the wild. Last week we did talk about junctional rhythms, and the big thing I want you to remember with junctional rhythms is that P waves can be inverted and in front of the Qrs complex. They can be buried within the Qrs complex, or they can be retrograde where they are behind the Qrs complex. And then of course we talked about our friend SVT, which is a narrow, fast rate with absent P waves, and should be pretty easy to distinguish at this point. So today we're going to move into our ventricular rhythms, and a couple of things I want to point out before we get started is that ventricular rhythms tend to be wide, and remember we say anything is wide if it's greater than 120 milliseconds or 3 small boxes. Remember the intrinsic rate of the ventricle is 20 to 40, and that's going to become important here in just a little bit and also important next week when we talk about AV blocks. The other thing that's interesting about the ventricles is, as opposed to the atria where it can be somewhat difficult depending on the size of the P waves to tell how many foci we're dealing with, in the ventricles every focus of the ventricle is going to look different from a different focus. So it's pretty easy to tell if we have multiple spots of irregularity versus just one based on whether or not they look the same. So let's start by looking at this rhythm here. So what you notice in this rhythm is we have these wide Qrs complexes, and just for the record, this is one lead, this is another, so I'm going to focus on one at a time. So we have wide Qrs complexes, and this one looks a little different from this one, looks a whole lot different from that one. Since they look different, we can very reliably say these are multifocal. And when I say they're multifocal, what I'm saying is they're coming from different spots within the ventricle. And down here it's actually a lot easier to see in this other one. So here's a Qrs complex, here's a Qrs complex, and here's a Qrs complex. And so these are all different from one another. They're very obviously different. And so this also proves our point about this being multifocal. Now there's something else we can see here, which is that our native rhythm, which is this and this and then this and this. So this is a sinus rhythm as our native rhythm. I'm going to erase this to make it a little bit easier to see, but what you'll notice is you have 2 beats of a sinus rhythm, and then you have a PVC, and then you have 2 beats of a sinus rhythm, and then you have a PVC. And when this happens, this is ventricular trigeminy. So trigeminy. And what trigeminy means is every third beat we're going to have a PVC, as opposed to bigeminy, which means every second beat we have a PVC. So this turns out to be normal sinus rhythm with trigeminy, multifocal, PVC. So as we move down here, let's take a look at this one. So in this rhythm, we have a couple of different things going on. One is we have our ventricular stuff heading right here, and then we have our native rhythm back in here. So let's dissect these things independently of one another. So it appears that our native rhythm is going to meet the criteria for atrial fibrillation, right? So we've got our scribbly lines drawn by the 6-year-old. We've got a relatively narrow Qrs complex, and we've got irregularity noted here as well. And then over here we have some wide, bizarre Qrs complexes. And these wide, bizarre Qrs complexes look like they are relatively the same, so they probably come from the same focus. So now what we need to do is put all this together. So we've already said we have atrial fibrillation as our underlying native rhythm. And then we're going to have a pair of PVCs. And these are unifocal. And when you have a pair, we call that a couplet. Okay, so a pair is a couplet where if you had 3 of them, you might have a trio of PVCs. But most commonly, we're going to see a couplet. So this is AFib, relatively normal rate, with a PVC couplet. Okay, be very concerned that when you start seeing couplets and triplets, because if you have couplets and triplets, then you're going to definitely be thinking about somebody who wants to go into ventricular tachycardia. As we move down here, we see our wide, bizarre Qrs complexes again. So here's a wide, 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 here's a wide. Okay, and then our underlying rhythm is going to be the things that are not the PVCs, right? So our underlying rhythm is this, and this, and this, and this, and this, and this. And so this is sinus rhythm. And since we have sinus rhythm and every other beat is a PVC, we're going to call this sinus rhythm with bigeminy. Okay. And then as we work our way down here, here's another example of trigeminy that I showed you before. So as we look at our native rhythm, we have sinus rhythm, we have sinus rhythm, we have sinus rhythm, and we have sinus rhythm, and then every third beat is a unifocal PVC, so this is ventricular trigeminy. As we move our way down here, this is a more interesting rhythm. This is something you need to be on the lookout for. And what we have here is just a series of wide, bizarre, almost looks like something from trigonometry or geometry, right? It's just a wide, bizarre rhythm. You'll notice that the speed of this is pretty fast. This is about 150 beats per minute. And you'll notice that there are no P waves. There are no normal Qrs complexes. So we can't answer the questions about is there a P before every QRS, a QRS after P, anything like that. There are just none to be had, and so you have a wide, bizarre, fast 150 beat per minute rhythm, and this is called ventricular tachycardia. Okay. Now, one of the things we could spend a little bit of time talking about is the fact that there are other things that can be wide and fast, which in general we just call these wide complex tachycardias. But in this particular instance, this is garden variety classic VTAC here. This down here, a little more interesting, it's another ventricular rhythm. And so what you'll notice here is we have wide QRS complexes, so that's a clue that this is coming from the ventricle. And then we don't see any P waves, and so that's another clue that this is coming from the ventricle. And then we notice the rate of this is very slow, right? This rate is around 40. And so when you have a wide QRS complex with no P waves and something that fits within that intrinsic rate of 20 to 40, then this is going to be what's called idioventricular. Okay. And then as we move along here, this rhythm looks completely different than our other ventricular rhythms. This is a death rhythm. first thing you should do when you see this rhythm is to check your patient's pulse. But this is called ventricular fibrillation, and ventricular fibrillation is basically an absence of any atrial activity, an absence of any ventricular activity. And when I say ventricular activity specifically, I'm talking about activity that relates to contraction of the ventricles. So at this particular case, the ventricles are just quivering and not pumping any blood, and so your patient will be pulseless, and this responds to tincture of house current, also known as defibrillation. So when we talk about defibrillation, we're using defibrillation when we have fibrillation. So defibrillators are used to treat the fibrillation. Okay guys, we just have a couple more things to talk about, and then we'll wrap all this up, tie it all together. This next rhythm here that we see is the easiest of all rhythms to identify, and it's called asystole. And some people call this ventricular standstill, but what you'll notice is just essentially a straight line. This is the flat line on the TV, on the movies. This is the long beep. This is not amenable to shocking, so do not shock this because it's not going to help. We can try to give medicines, but they rarely help, and it's very rare that somebody comes from asystole back to a beating heart, although it's not impossible. So this is asystole. This is just the old flat line, and should be the easiest of all rhythms. The last rhythm we need to talk about is the paced rhythm. And so here what you see is you see these little doohickeys right here. These are pacer spikes. In this case, this is a atrial and ventricular pacer. So you see a pacer spike right here before the P wave, and then you see pacer spikes here before the Qrs complexes. Now, one of the things I want to discuss with you is the fact that paced rhythms tend to be wide, and I'm going to show you why that is. So if we go back to our drawing of the heart, and we recall that the vena cava come in here to the atria. So there's a blood vessel over here called the subclavian vein, and so usually what will happen is the cardiologist will bring the wires through the subclavian vein and down here into the heart, and then the ventricular lead will live in the right ventricle, and the atrial lead will live in the right atria. So what happens then is the right ventricle will fire first, and then it'll depolarize from right to left. And so by doing that, it causes a delay in depolarization as opposed to our normal depolarization, which of course would come straight down here and then go both ways simultaneously. So we get a slight delay in depolarization, and it causes a wide Qrs complex. While we're on the subject of wide Qrs complexes, I do want to mention something about wide Qrs complexes when we're looking at rhythms. So if you're looking at a rhythm and you see a P wave plus a wide Qrs complex, that's typically going to be a bundle branch block. And what a bundle branch block means is, if we go back to our drawing here, and we know we've got these bundles of His that come along here into each side. In the bundle branch block, then one of them will be blocked and the other one has to take over. So for example, if you have a right bundle branch block and electrical conduction can't get past there, then the left side will depolarize, and then it will depolarize from left to right. Similarly, if you have a left bundle branch block, you'll block over here, electricity will come over this way and depolarize from right to left. And in that situation, that's called a bundle branch block. And we'll talk about, when we get into 12 leads in a couple of weeks, how to differentiate a right bundle from a left bundle, which you really aren't going to be able to do in a single lead tracing. But what I want you to know right now is a P wave with a wide Qrs complex is a bundle branch block. If you have a wide Qrs complex with no P wave, then this is going to be ventricular in origin. Okay, and that's going to be the big way that we're going to sort these out. So just as a quick review then, we have our Qrs complexes are going to be narrow above, they're going to be wide below, and we talked about PVCs. We talked about they can be multifocal, or they can be monofocal, okay, or unifocal. And that tells you how many foci they're coming from. So if they're multifocal, they're going to have different morphologies, different appearances. We talked about if you have 2 PVCs, it's called a couplet. If you have 3, it's called a triplet, so couplet and a triplet. And these patients, you need to be careful because they may go into ventricular tachycardia. We talked about bigeminy, which is when you have a PVC every other Qrs complex, or trigeminy when you have one every third. We also discussed the fact that you need to figure out what the underlying rhythm is, and then we name the rhythm based on the underlying rhythm plus whatever the ventricles are doing. So sinus rhythm plus bigeminal PVC, or atrial fibrillation plus multifocal PVC, or whatever the case may be. So find the underlying rhythm first and then figure out what is going on with the ventricle. So that's all I have for you on this lesson. I apologize for the background noise that's probably present on this lesson, but that's all for now.